Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
Urinary tract infections. They're actually the second most common infection you're going to encounter in clinical practice. So mastering the pharmacology of the drugs we use to treat them isn't just about passing an exam. It's absolutely critical for keeping patients safe. So let's dive right in.
Here's our game plan for today. We're going to keep it systematic. First, we'll lay the groundwork and define the clinical problem of UTIs. Then, we'll really get into the pharmacology of the key drug classes, starting with our prototype, cotrimoxazole. From there, we'll cover some other essential agents and then wrap it all up by pulling together the most high-yield info for your clinicals and your board exams.
Okay, so let's start with the basics. Before we can even talk about the drugs, we have to understand the clinical problem we're actually trying to solve.
Now, you have to know that not all UTIs are created equal. We make a really crucial distinction based on anatomy. You've got your lower UTIs, which involve the bladder and urethra. Think cystitis or urethritis. These are by far the most common. But when that infection decides to travel up to the kidneys, we're suddenly dealing with an upper UTI, also known as pyelonephritis. And this is a critical distinction to make because upper UTIs are always considered more serious and require much more aggressive treatment.
Here are some key high-yield facts you just have to know. UTIs are incredibly common, especially in women. We're talking a 30-to-1 ratio compared to men. The microbiology is also very predictable, which is great for us. The main culprit about 80% of the time is the gram-negative rod E. coli. And if you're thinking about a gram-positive cause, the one to have on your radar is Staphylococcus saprophyticus.
All right, let's move into our first drug class. We're going to use cotrimoxazole as our prototype. And here's why that's so important. If you can really nail down this one drug, from its mechanism all the way to its side effects, you're building a mental framework for the entire class of folate antagonists. It's a really effective way to learn.
The very first core concept you have to grasp with cotrimoxazole is synergism. See, it isn't actually one drug, but two working together. Sulfamethoxazole, or SMX, and trimethoprim, or TMP. By themselves, these agents are just bacteriostatic, meaning they only stop bacteria from growing. But when you put them together, their combined effect is so much greater that they actually kill the bacteria, making the combination bactericidal. This is a classic high-yield example of pharmacologic synergy that you'll definitely be tested on.
So how in the world is this synergy achieved? Well, it's through a really elegant mechanism known as a sequential blockade. You see, bacteria need to make their own folic acid to build DNA. Sulfamethoxazole blocks the very first enzyme in that pathway. Then, trimethoprim comes in and blocks a second enzyme further down the line. By hitting the same pathway at two different points, they completely shut down the production line for tetrahydrofolate, starving the bacteria of the building blocks it needs for DNA and survival. It's brilliant, really.
When we look at the pharmacokinetics, you'll see the two components behave pretty differently in the body. Trimethoprim is more lipid-soluble. What does that mean for us? It means it can distribute more widely, and, this is really important, it concentrates in acidic tissues like the prostate and vaginal fluids. This makes it super effective for infections in those specific areas. Sulfamethoxazole, on the other hand, has higher protein binding and gets metabolized in the liver before it's excreted.
Okay, let's talk adverse effects. And the most crucial thing to focus on here are the hematologic toxicities. This is where the big exam questions are. Because trimethoprim messes with folate synthesis, it can also have a mild effect on our folate pathways, which can lead to megaloblastic anemia. But even more critical, and this is a must-know association, is the risk of triggering acute hemolytic anemia in patients with G6PD deficiency. You have to have that connection locked in.
We also have to be really careful with drug interactions. Cotrimoxazole can ramp up the effects of other drugs that are highly protein-bound, like the blood thinner warfarin. And this next point is clinically vital. It can actually knock bilirubin off of albumin. Now, why does that matter? Well, in a newborn, that free-floating bilirubin can get into the brain and cause a dangerous condition called kernicterus. And that risk of kernicterus leads us directly to our key contraindications. This is why cotrimoxazole is an absolute no-go in late pregnancy, in nursing mothers, and in infants younger than 6 weeks old. It's also just good practice to avoid it in patients who already have severe kidney or liver problems or any pre-existing blood disorders.
All right, let's switch gears and talk about our next drug, nitrofurantoin. This one is really unique. It's not a systemic antibiotic in the way we usually think of them. Instead, it's classified as a urinary antiseptic, which means its action is pretty much confined entirely to the urinary tract.
Its mechanism of action is actually pretty clever. Nitrofurantoin acts as a prodrug, so once it gets inside a bacterial cell, the bacteria's own reductase enzymes activate it, turning it into these highly reactive agents. These little agents then just wreak havoc inside the cell, damaging bacterial DNA and messing up all sorts of other cellular processes, which ultimately kills the bacterium.
The pharmacokinetics of nitrofurantoin are what strictly define its clinical use. It gets absorbed, but then it's metabolized and excreted by the kidneys so fast that it never reaches a high enough concentration in the blood to do anything systemically. This makes it useless for a systemic infection, but it makes it perfect for uncomplicated lower UTIs because it concentrates right where we need it, in the urine. And a key counseling point for your patients is that it will turn their urine a dark orange-brown color, but you have to reassure them that this is completely harmless.
In terms of side effects, GI upset is pretty common, so it's a good idea to take it with food. But notice the red flag that we've seen before. Just like cotrimoxazole, nitrofurantoin can trigger hemolysis in patients with G6PD deficiency. This makes G6PD deficiency a critical contraindication, along with its use in newborns.
Next up, let's look at two protein synthesis inhibitors. Now, even though doxycycline and gentamicin both have the same general target, the bacterial ribosome, their pharmacological profiles, their uses, and their toxicities are really worlds apart. Let's compare them head-to-head. Yes, both of them target the 30S ribosomal subunit to stop protein synthesis, but that's pretty much where the similarities end. Doxycycline is bacteriostatic, and you take it orally. Gentamicin is bactericidal and has to be given parenterally. Their toxicity profiles are also completely different and totally high yield. For doxycycline, you need to associate it with bone and teeth discoloration. For gentamicin, the key toxicities are to the ear and the kidney. That's ototoxicity and nephrotoxicity.
Here's a huge pharmacokinetic principle for doxycycline. Its oral absorption is seriously impaired by di- and trivalent cations. So think calcium in milk, magnesium in antacids, or iron supplements. Why? Because it chelates or binds to these ions. And that very same mechanism is what explains its main contraindication. By binding to calcium, it actually gets incorporated into developing bones and teeth, causing permanent staining. That is why it is absolutely contraindicated in pregnancy and in children under 8 years of age.
Okay, now for gentamicin. First off, because it's so poorly absorbed, it has to be given IV or IM. It's a really potent bactericidal drug against gram-negative aerobes. But the most critical point for your clinical practice is that you have to be constantly monitoring for its major toxicities. You have to watch for any signs of hearing or balance problems, which would indicate ototoxicity, and you have to keep a close eye on kidney function for any sign of nephrotoxicity.
So what happens when we're dealing with more severe or resistant UTIs? Well, that's when we have to escalate our therapy to other powerful classes, specifically the third-generation cephalosporins and the fluoroquinolones.
Let's quickly compare these two classes. Third-generation cephalosporins, with ceftriaxone as our example, work by inhibiting bacterial cell wall synthesis. These are our go-to drugs for severe, complicated UTIs like pyelonephritis. Then you have the fluoroquinolones, like ciprofloxacin. They work by inhibiting an enzyme called DNA gyrase, which stops the bacteria from replicating its DNA. We generally reserve these for infections caused by multi-drug-resistant bugs. It's also super important to be aware of the serious potential side effects with fluoroquinolones, like tendon rupture and QTC prolongation.
Wow, we've covered a significant amount of pharmacology. So now let's take a moment to synthesize all this information and really distill it down to the most critical high-yield pearls that you're going to need for your exams and your clinical rotations.
This is your rapid review slide. For cotrimoxazole, you have to lock in that association with G6PD deficiency, pregnancy, and folate antagonism. For nitrofurantoin, remember, it is a urinary antiseptic only, also contraindicated in G6PD deficiency, and it turns the urine brown. For doxycycline, the big contraindication is children under 8, and that's a direct result of its calcium chelation. And finally, for gentamicin, the keywords are and always will be ototoxicity and nephrotoxicity.
And to wrap it all up, let's apply this knowledge with a quick clinical scenario. A patient comes in with an uncomplicated UTI, and their chart says they have a known G6PD deficiency. Based on everything we just discussed, which two of these drugs are strongly contraindicated because of that high risk of causing acute hemolytic anemia? If you can answer this, you're not just memorizing facts, you're demonstrating true clinical understanding.